Hi, this is Brian Kim. I'm going to share with you case number 196 in the Best Way to Do Cataract Surgery series. This is a patient with a small pupil, and I'm going to show you how to efficiently and safely disassemble the lens in a small pupil case with double chop and cross chop. Remember, with double chop and cross chop, I'm able to ensure that I am within the capsular bag when I execute the chop techniques, and therefore, because I have my methods to do this, even in small pupil cases when you can't directly visualize a Rhexis, you're able to effectively achieve lens disassembly even in a small pupil case. So you can see here this patient has a relatively small pupil. I'm going to go ahead and use a cotton tip to steady the eye and center the eye. And this is a corneal marker which will help me to center and size the Rhexis. And using that cotton tip, I'm immobilizing the eye, turning it towards the left there. I'm making my paracentesis incision first on the right side and then the left side, making sure I'm parallel to iris plane, which creates a nice corneal shelf, which will allow me to achieve a self-sealing incision. This is intracameral epinephrine, and then some dispersive viscoelastic to coat the corneal endothelium, flatten the anterior capsule, and in this case also some viscodilation. And this is a triplanar corneal incision. I make a vertical groove, place the blade into the deep part of the groove, tunnel, and then I enter. And these are the sharp tip Haldi-Perkar forceps. Go ahead and puncture the center with the teeth closed. Because of the sharp tip, it's effectively like a cystotome needle. I puncture, pull down towards me, grab the right side of the tear, going around circumferentially, grabbing and re-grabbing, redirecting the forces, and then using that corneal mark that I made to help guide the size and centration of the Rhexis. Burp some viscoelastic out, and this is the capsule fornix hydrodissection technique. I place the cannula under the Rhexis edge contra-incisionally, point the tip down, get a nice wave, decompress, go ahead and sweeping underneath the left side and then the right side. This is an older case. As you saw, I didn't lift the lens when I did the hydrodissection, so this is an older case. Now I routinely lift because this gives me more assurances I'll be able to decompress the bag. Irrigate the surface of the eye, lifting the incision with a chopper, going in with irrigation off to minimize Descemet's trauma, removing the surface epinuclear material. You see how I'm holding the chopper, the tip is the leading edge, and therefore I'm able to go under the Rhexis edge very confidently, sliding it under right now, turning it vertically into the capsule fornix, turning the phaco tip vertically subincisionally, fracturing the lens in half. Placing the chopper around the right heminucleus, hooking the peripheral lens, pulling it centrally toward the phaco tip, and crushing the lens against the phaco tip like a chopping block. Getting the chopper around that first quadrant, crushing the lens between the instruments, doing the same thing around that second quadrant, another cross chop maneuver, lifting that fragment with some vacuum, crushing the lens between the instruments, and then emulsifying the lens pieces. Again, because I always turn the chopper tip as the leading edge of it, I'm able to push down on the lens material, and by doing that, I'm able to ensure that I'm going underneath the Rhexis every time. And it just comes down to practice and understanding where your instruments are in the eye. It's no different from when you're driving and your foot pedal is controlling the acceleration and brake. You don't have to look at your feet in order to know what you're doing. You just know. So I turn that second heminucleus in front of me, placing the chopper under the Rhexis edge, crushing the lens against the phaco tip and bisecting that second heminucleus. Doing the same maneuver with the cross chop maneuver around that third quadrant, crushing the lens between the instruments and emulsifying the lens pieces. And by doing it this way, you can see how easy and efficient it is. I'm not struggling to grab pieces. Every time you go after it with vacuum, it slips off sometimes. It can be rather frustrating, especially if the lens is stuck within the bag. And then if you go after pieces with high vacuum out of habit, then you might accidentally do something you shouldn't do. And everything comes down to risk management. Again, 99% of the time, if you go after pieces with a high vacuum, it's not going to be a problem. 99% of the time, when you do your traditional cataract surgery technique, you're not going to have a problem. It comes down to that 1%. This technique eliminates that 1% problem because you're not relying on high vacuum, you're not relying on ultrasonic energy, you're just hooking the peripheral lens with the chopper. You're able to leverage mechanical forces by crushing the lens with the instruments with opposing forces, and by doing this in any which angle, because of the cross-chop technique, it's very versatile. So I take the chopper out, push BSS in, take the phaco tip out, and I go in with the INA handpiece. I go around circumferentially, trying to grab from anterior to posterior. By grabbing anterior to posterior, you're going to get a cleaner peeling of the cortical material. Sometimes it works the way you want to, sometimes it doesn't. Go ahead and switch to polish mode, polishing underneath the Rhexis edge. You saw I lifted the iris because it was in a little bit of a reverse pupillary block from the fluid. And again, that has to do probably with the stretchy nature of the iris in this small pupil case. Once I'm confident that the bag is clean, I'm going to go ahead and pulse BSS into the subincisional capsular fornix. And this is some cohesive viscoelastic to fill the capsular bag. And I'm trying to see if I can find the Rhexis edge. And in the cases when I can't really see it very well, I will usually bypass the sweep maneuver. And I go ahead and straight to the lens. And I'm turning the eye away from me so I can see the contralateral Rhexis edge, making sure the lens goes underneath the Rhexis edge. And then switch to IA, go in with irrigation off, activate irrigation, and I have the Maltzman ready to go. You can use a Lester or Kugelin, it doesn't really matter, but something that you can retract the pupillary edge to ensure that the lens is completely within the bag. What you don't want to do is you do a beautiful case and you do a sloppy job of putting the lens in, and you have one haptic in the sulcus, one in the bag, and I hate to say it, but really that is inexcusable. You should be able to put the lens where you think it is, and all it takes is just an extra step of retracting the iris, and then you'll know exactly where the haptic is. You don't really want to, other things happen, if you're doing cataract surgery, and unfortunately, you can have posterior capsular rupture, things like that. Those are just unexpected things that can happen in surgery. But something like this, leaving a haptic in the sulcus, to me, that's really not an excusable event. You should always be able to retract the iris with an instrument, ensuring that both haptics are in the bag. Once I'm done with that, I go ahead and remove all the viscoelastic from the anterior chamber, and then I'll hydrate my incision. So again, this is a patient who has a small pupil. As you've seen with my techniques, double chop, cross chop, mechanical fracturing does not require direct visualization. Why? Because once you make the Rhexis and you remove the surface epinuclear material, I'm able to pronate my hand, making sure the tip of the chopper is out towards the periphery. And as I place the chopper out to the equator, I'm leading with the tip. And since I'm rotating it sideways, it's fairly flat. And I'm able to push down on the lens material, slide it underneath the Rhexis edge. And when I get to where I need to, I straighten out so that chopper is now, the tip is pointed down, so it's in a vertical position. It's out to the equator. It's hugging the peripheral lens. I turn the phaco tip vertically subincisionally. I'm able to fracture the lens. Remember, the phaco tip, even though it doesn't go out to the equator, I'm able to stab it like a shovel stabs into the ground. It just creates that grabbing point, some leverage. And then I'm able to fracture the lens primarily with the chopper. The chopper is really the main cutting force when you're performing double chop. And then I pronate my hand once again, placing it around the right heminucleus and then straightening it out and then pulling it centrally toward the phaco tip. And the reason why cross chop works is you're pulling the chopper towards the center. The lens material is in between the chopper and the phaco tip. And when it encounters the phaco tip, the lens material is crushed against the phaco tip, no different from a chopping block. And then you're performing multiple cross-chop maneuvers. Again, because you're able to slide the chopper underneath the lens, you never worry about being around the zonules or the bag. And you don't really need direct visualization with this technique. And therefore, I don't really use rings. I don't really use hooks. when I deal with small pupil cases. The only time I would use a retraction device is, one, if it's a very dense lens, and number two, if there's significant zonulopathy. I don't really take chances in those situations. You really want to have good visualization, and since you're using a lot of ultrasonic energy in those cases, you certainly don't want to accidentally grab something like the iris and so forth. And so other than that though, anything around 2+ or less, I feel very confident not retracting the pupil. Remember, messing with the iris causes trauma as well. You're going to break down the blood aqueous barrier by doing that. No reason to do that, but again, your limitations based upon your technique, not based upon mine. And so you just have to ask yourself, is it worth it? And if it's not, just do your normal technique and go ahead and use rings or hooks. That's fine. But with my technique, I don't really feel like I need to do that. And as you can see, this case is a perfect illustration of that. So I hope this was helpful to you, and I thank you for your attention.